Namaste, good afternoon. How have you all been? I'm Dr. Srinidhi Chidambaram, and I'm delighted to welcome you to the FB Live session presented by Apollo Hospitals to create awareness and knowledge on health, disease, and lifestyle, as well as to tell you all about the latest treatments and innovations in healthcare. Pediatric cardiology has been a relatively neglected specialty in India despite a massive disease burden. There are many factors like consanguinity, viral infections like mumps, measles, and rubella, lack of awareness, which all contribute to the high disease burden of pediatric heart disease. And data actually says that almost 8 children out of every 1,000 live births are born with heart diseases. And most of these children do succumb to the disease without treatment, but in contrast, with timely treatment, they could grow up to lead normal lives. It's very psychologically distressing and daunting indeed for families when they need to care for their baby diagnosed with a heart disease. So it is always useful to get equipped with knowledge on what the latest life saving innovations are so that one can seek the best medical care at the earliest and get the best outcomes and ensure survival of the baby, and also take reassurance from the fact that many of these pediatric heart diseases can now get completely resolved with the latest treatments and innovations. So, to educate us and tell us about this very important topic of life saving innovations in pediatric heart care, I'm delighted to welcome Dr. Ashutosh Marwah, Senior Consultant, Cardiology, Apollo Indraprastha Hospital, New Delhi. Dr. Marwah completed his MBBS in the Maulana Azad Medical College, University of Delhi, and then his MD in Pediatrics from the same institution. He has done his fellowship in pediatric cardiology from the Escorts Heart Institute, Delhi, and also a fellowship in pediatric cardiology from the Royal Children's Hospital, Melbourne, Australia. He has over 19 years of experience in this field and is well versed in non invasive imaging of complex congenital heart defects, has done more than 1,000 diagnostic cardiac catheterization, more than 700 interventional cardiac catheterizations, including device closure of atrial septal defects, device and coil closure of PDAs, balloon dilatation of aortic valve, pulmonary valves, and treatment of coarctation of aorta. He's well versed with neonatal interventions, including balloon atrial septostomy, dilatation of critical aortic, and pulmonary stenosis. Welcome, Dr. Marwah. I'm so happy that you are here today to explain about pediatric heart disease and the latest innovations in their treatment. Over to you.
Thank you, Dr. Shendri. As you've pointed out very correctly, pediatric cardiology is has been sort of neglected branch in India. Initially, it was practiced mainly by the adult cardiologists who would branch into pediatric cardiology and start looking after children. But there was no thing called as pediatric cardiology per se. Fortunately, now we have the DNP programs in pediatric cardiology. We have and DMs in pediatric cardiology. So yes, we have moved quite far from when I started, when there was nothing like a pediatric cardiology. So it's an evolving science. In last 2-3 decades, we have seen lots of advancements in pediatric cardiac on the cardiology side as well as on the surgical side. So I think right from the imaging, our imaging is improved so advanced now, like we are able to pick up the defects right within the mother's body. So 20 weeks, we are able to pick up major congenital abnormalities. So we know which is the child who is going to be a critical patient, who is going to require an intervention soon after birth. So all those, babies can be planned to deliver in an institution where the facilities are available, because had not been for this imaging, these babies would have been delivered in an unsupervised place or another hospital, and we would have lost this child. Then I think the another advancement that has happened is miniaturization of our equipment. So our equipment now, it is so fine that we can do an intervention in cath lab even in a 2 kg baby. So we don't need thick balloons, thick wires. Our equipment has been adapted to cater to these small babies. Similarly, on the surgical side, with the advancement in technology, our surgeons are capable of operating even small and small children, like 1.8, 1.5. The comfort zone has increased. It is due to improvement in your experience. Second is adaptation of the equipment to suit such small children. Because there was a time when I started, it said that 10 kg से ऊपर होगा बच्चा तब सर्जरी हो सकती है या तब इंटरवेंशन कर सकते हैं. Now we don't even talk of 10 kg. 10 kg is gone. We only say, okay, fine, this can be fixed. We don't even many times look at the weight of the baby, because life-saving intervention, we cannot look at the weight. We are operating neonates. We are operating electively delivering neonates near term or borderline term to handle them in cath lab, as well as surgery if the child is decompensating within the mother's body. So yes, things have taken a huge jump, I would say that. And now there is a total specialization of pediatric intensivist, pediatric cardiac surgeons, pediatric cardiology. That itself is a big advancement. Then historically, if you say so, availability of prostaglandin, that's something that changed the scenario. Prostaglandin could be utilized in children who were duct-dependent circulations to open up the patent ductus arteriosus at birth, and to be able to shift the child from periphery to a center where the cardiac care was available. Had it not been for prostin, the shifting of such child would not have been possible. We would have lost those children. So yes, there are advancement in our medications, surgical things, imaging, and of course our equipment, which is now more suited, for the smaller babies. Then with the coming of Berlin heart, which is now adapted to children as 10 kg or so. So even children who are waiting for transplant, they can lead a sort of healthy life rather than becoming ventilator dependent. So there are lots of advances, and it's still evolving. Things are still evolving.
So, could we now begin by talking about what are the common heart conditions that are likely to occur in babies in the neonatal and pediatric age groups?
To classify broadly, we would say there are defects which are simpler lesions. Simpler lesions would mean our routine atrial septal defects, or ventricular septal defects, or a patent ductus arteriosus, where we say a hole in the heart, or a valvular obstructions, where we say valve stenosis. Whereas to the complexities where you have cyanotic heart diseases with like tetralogy of Fellows, where you have a VSD along with obstruction to the pulmonary artery or pulmonary valve, or a single ventricle physiology where the heart is not being divided into four chambers; it's remained three-chambered heart, and everything is getting mixed. So we have a huge spectrum of conditions, um, from simpler ones to as complicated as hypoplastic left heart syndrome, where you do not have the left ventricle completely developed, there is no aorta or aortic atresia is there. So there is a huge spectrum. Some of them are easily rectifiable, where children leading normal lives, full normal lives with full potential, whereas certain conditions like very complicated single ventricles are palliated. Palliated in the sense like we give them best possible life, but we cannot give them 100%, but it's still better than not having any treatment.
Are there any risk factors for these? Are they preventable in a sense that is there something that people should be aware of so that these kind of congenital heart diseases can be avoided?
Uh, there are certain known risk factors and certain unknowns. Unknowns we do not know. Knowns, yes, mothers who are on any medications like phenytoin, warfarin, patients, mothers with diabetes, uh, where you have high risk of developing hypoplastic left heart or transpositions. Then maternal rubella, if the mother gets a rubella infection during pregnancy, then the child is likely to have deafness, child is likely to have PDAs. So these are certain known conditions. But then there could be many environmental factors, such as exposure to environmental toxins has somewhere been related to total anomalous pulmonary venous drainage. And then hosts of unknown and genetic factors. Sometimes late pregnancies in the sense like these are the days when most of women are postponing their pregnancies, late 30s or early 40s, but that does increase the risk of having the babies with Down syndromes, which is having an extra chromosome in your body, and 50% of Down syndrome babies are going to have heart defects. So these are add-on factors. Then consanguinity, high degree of consanguinity, whichever society has, we have seen more complex kind of heart disease. So in nature, we see probably 8 to 10 per thousand live births as heart disease, babies born with heart disease, but probably there are few more which are being missed as spontaneous abortions or midterm abortions, those which were not compatible with life at all. So autopsy series, if you look at, the number is actually much higher. But yes, live births, if you look at, it's probably 8 to 10 per thousand in any given society.
So, are there also any acquired heart diseases that children might get?
Acquired heart diseases could be in the form of myopathies. Most common we see in India is viral myocarditis or post-viral myocarditis, dilated cardiomyopathy, where the cardiac function goes down, and most of the time we end up giving them immunoglobulin. And recently we saw patients with MISC. COVID is there, and a lot of children who came with post-COVID multi-inflammatory syndrome, they presented with cardiac dysfunction. They presented with coronary artery dilatation, which was similar to Kawasaki disease, and it responded very well to giving immunoglobulins and aspirin. Again, Kawasaki disease is one more acquired heart disease. Then another acquired heart disease is rheumatic heart disease, which is because of streptococcal infection. And then you have the cardiac lesions, which come as a secondary effect to it, and valvular leaks as well as valvular stenosis. Fortunately, with urbanization and improved medical care, the incidence of rheumatic heart disease is probably going down in our country.
So, what advice would you give to parents as to whether it's a newborn or whether it's a slightly older child? What are the early symptoms that they must be aware of and seek early medical intervention?
Uh, okay, if you look at a baby who's born, and let me talk of very simple basic heart disease, say let us say a ventricular septal defect, it's a significant defect, then this child usually will become symptomatic by 4 to 6 weeks of life. So they will have, episodes of fast breathing. This child doesn't feed well, gets sweaty, and will have what we call a sleep, suck, sleep cycle. Like he sleeps, then he sucks a while, takes a feed, but is not able to satisfy his hunger because he's not able to suck properly, gets tired, goes off to sleep. And this is the child who's not going to gain weight. So these are simpler shunt lesions. But then with complexity of heart disease, you can have children with, where the pulmonary blood flow is less, that is tetralogy of fellow kind of lesion, which have obstruction to the pulmonary valves. The blood is not, enough blood is not going into the lungs. So these children start getting blue nails, blue lips. They start having incessant crying, becoming unconscious. So these are the other kind of symptoms. Then sometimes, with minor heart disease, say a mild valvular AS or a mild, small VSD, it's the pediatrician who will pick up a murmur in the heart. So the presentation, I would say, mainly would be for simpler condition is child not putting on weight, child getting repeatedly into chest infections, not able to feed properly, excessive sweatiness, and on the other side, if there is any blueness of nails and lips, which could signify a significant complex heart disease.
We also have heard about prenatal diagnosis of heart disease. So, could you explain how that is done and in what circumstances?
Prenatal diagnosis of heart disease, as I said, is a fetal echocardiography. Fetal echocardiography is recommended. We don't recommend for everyone. It is recommended when your routine ultrasound, which is being done by the gynecologist or the ultrasonologist, shows abnormal heart. If they are not able to pick up four-chamber heart and if they feel there is something abnormal, then of course the child needs to be evaluated by a pediatric cardiology. Fetal echo can be done. Then the others are mothers at risk. They are mothers who are elderly, mothers who have conceived through difficult, say IVF, sometimes or multiple pregnancies, polyhydramnios, mothers with oligohydramnios, diabetes, then mothers who are on medications of some kinds, mothers who have been diagnosed to have SLE. SLE is something which really does not cause a cardiac defect per se, but it does damage your conduction system. So the babies are born with heart block, and then these are the children who will require pacemaker right at birth. So all these pregnancies need to be monitored by the, I say not monitored, evaluated once by the pediatric cardiologist, and detailed diagnosis can be made. And once you have the diagnosis, you can decide whether this child will require, is a critical condition and will require institutional delivery, or can be delivered and later on seen later on.
The question of treating the congenital or neonatal heart disease, there is always both the surgical and the non-surgical. So could you explain to us what is the surgical and what are the non-surgical options, and where is what used? Like which one is suitable for which disease?
I would say simple conditions like valvular obstructions, where you have the valve obstruction of the aortic valve or the pulmonary valve, or there is a stenosis of the blood vessels such as coarctation of aorta. These can be simply ballooned in the cath lab. Sorry. Then atrial septal defects of certain kind, that is only the fossa ovalis ASD, which is well-centered defect, can be closed in cath lab using a device. Or a patent ductus arteriosus beyond neonatal age group can be closed in the cath lab with a device. Most of the other conditions probably will go to the surgeon's field if they require an intervention. So it is the decision which is made by your cardiologist along with the surgical team, or rather that, okay, fine, this is where the cardiologist will take over and this is where the surgical expertise will be.
We've heard of something called the 3D printed technology in treating complex heart disease in children. So could you just give us an overview of what this is about?
Yeah. See, what happens is many times there are very complex heart diseases, such as what we call as a double outlet right ventricle, where both the outflow tracts, the aorta and the pulmonary artery, are committed into the right chamber, and left ventricle has no blood vessel to it but has a big VSD. So many times the cardiologist and the surgeon have to decide whether this hole can be closed in such a manner that aorta or the pulmonary artery, either of the two vessels, preferably aorta, can become part of the left ventricle. So heart is a three-dimensional structure, whereas echocardiography gives us a two-dimensional images. So a three-dimensional printed models help in deciding, it's through the computer generated technique. So we get the 3D printed models. It helps in deciding the best surgical option for a patient. It will give us the exact length of the patch to be used, exact curvature that the patch has to be inserted into, so that we get clear planes and the left ventricle or the chambers can be connected to their respective vessels without encroaching upon the other chamber and without creating any obstructions to the outflow tract. So it is, I would say, a great help, a great tool. We have been using CT scans and cardiac 3D regenerations on CT scans, which give us the virtual thing. But now when you have the 3D computer generated models, the surgeon can play around with it, figure out the technique, and which is the best way to approach a particular complex defect, whether he should go, where the incision line could be there, and how to go ahead with
Doctor, we'll now take some questions from our
Yes.
viewers. Um, does a child need to be hospitalized for all these cardiac investigations?
No. Most cardiac assessments say echocardiography does not need hospitalization. It is done as routine day OPD procedure. Some children may require mild sedation to get good and optimum imaging. This is then the cardiac CT scans, which is routinely practiced in our institution, or a cardiac MRI. Again, we don't need to hospitalize the child. All we do is 4 hours fasting. Once the CT and or MRI is over, we keep the child in observation till the effect of sedation, if it has been used, goes away, 2 to 3 hours, and the child is sent home. So most diagnostic investigations do not need hospitalization. But if you're talking of angiography in pediatric patients, where you need to get into the heart, do a pressure and assessment, etc., yes, for that we hospitalize the child night before, because the child has to be fasting, proper PACs are done, and angiographies are done. So for 24 hours, we keep the child in house. But for other routine investigations, no.
Do babies with heart defects sleep more than others?
As I said, that child who's hungry gets tired, doesn't feed well, sleeps a while, then wakes up hungry again. So it's more of a shorter and irritable child who's hungry most of the time but has not been able to suck from the mother's breast. So probably sleeping is not a sign of heart disease per se. No, most children will probably sleep less because they have not been able to feed well.
Is a parent, can a parent pass on a heart disease to the baby?
Certain conditions where the genetic abnormalities are there, chromosomal abnormalities, say 22q microdeletion, where you have the 22nd chromosome and you have some deletion on that. Yes, they can be transmitted from one parent, and especially if you have a consanguinity kind of first degree consanguinity, where the mother and father have just carried that gene but have not manifested, then the baby can have full-blown manifestation of Dijon syndrome, which is also associated with tetralogy of Fallot. Similarly, certain rhythm abnormalities, long QT syndromes, etc., myopathies, hypertrophic cardiomyopathies also are known to occur in run-in families. Bicuspid aortic valve disease, aortic valve stenosis, we've seen clusters in families where children will have different manifestations. So yes, if the parent has been treated or suffered from congenital heart defect, either of the parents, we always recommend a fetal echo screening in such pregnancies.
In India, what are the common types of congenital heart disease?
We see every spectrum, ma'am. There's no difference. But the only thing is that, yes, probably we are still a growing country, a developing country, so we see more of survivors. Many children who probably do not reach to a tertiary care center, probably we don't see them, but we do see lots of, and as the awareness is growing, we are getting younger and younger children. The spectrum has completely shifted from earlier being children more than 2 years, 3 years coming to us. Now we are seeing children at 3 months, 2 months, even 1 month. So, and we have the entire spectrum, but yes, sometimes we do see delayed or late presentations. But good thing is, with the awareness, parents are coming early.
This is the last question. Are there any ventricular assist devices made separately for pediatric patients?
Yes, there are, and I actually can say that they have recently the Berlin heart modified for children was used, and they have used it even in a child who's probably about 2 years or something like that. So 12 kg. Yes, all these extracorporeal devices have been modified and are now suitable for children. They act as a bridge for the child while he's been waiting for the transplant. Yes, things are available, and we are improving with time.
So, thank you, Dr. Marwah, for your valuable time. And I do hope that our viewers have had a broad overview of the various types of heart diseases that can affect children. And as you yourself said, The more the awareness, the earlier treatment can be sought, and the better chances for helping the baby to lead as normal a life as possible. Thank you so much for your valuable inputs. And viewers, thank you for joining in. And please subscribe to our YouTube channel to get the latest information on our trending healthcare topics. If you have more queries, you know that you can always reach out to us on our Facebook page. Do stay safe and see you again soon. Thank you. And
Thank you, Dr. Nidhi. Thank you. Pleasure.